Pleasure of introducing Dr. Maisam Abu-El-Haija from Cincinnati Children's. She is an associate professor of pediatrics as well as the medical director for their Pancreas Care Center, and as well serves on as an education chair for the CAPER group. And she'll give an overview of pancreatic diseases in children.
Thank you, Walter, for the introduction. Good morning, everybody. So my task today is to cover overview of all pediatric pancreatic disorders in 20 minutes. So I will stick on time. And this is meant to be giving you a flavor of different aspects that affect children. I can come over and help you find them. Is it just loading? It's fine. So there are relevant topics in my talk that will be important for the pediatricians in the room and for the adult experts that manage these diseases, because not in every institution you will have access to pediatric colleagues that can help manage these cases. So there is also a crosstalk for transition medicine when you have adolescents who are growing up into young adults, and we all have to be familiar with what pediatricians do to hand off the patients to adult medicine. So I will cover acute pancreatitis, acute recurrent and chronic pancreatitis, congenital malformations like biliary choledochal cyst, pancreatic cyst, annular. I'm not going to be able to cover all the congenital things, but bear in mind when you're working up a patient in their young age, these are anatomic things that they might be born with that lead to disease. Exocrine insufficiency, which in children does not always mean chronic pancreatitis. And then endocrine disorders, I would probably not be able to focus on it as much, but Melina would. Pancreatic tumors in children, which has been a very hot topic recently, including at the EPC meeting when we attended last month. And then just keep in mind that pancreatic disorders could be also part of multi-system diseases that children are born with, like tuberous sclerosis or polycystic diseases. So we do have a challenging task. They're not drinking alcohol, they're not smoking. So we have to go back to the anatomy and what Dr. Gorelick taught us to kind of try to tease out these things. So I would start by saying that a group of us came in one room in 2012 and put definitions of acute pancreatitis. And while it might seem similar to what the definitions of acute pancreatitis are for adults, it was really the initial agreement that we have a definition that we can go by. And I consider this field to be really emerging from the time that we started defining the disease together the same way. So acute pancreatitis in children means you need to meet 2 out of the 3 criteria, which are the same criteria that you have for adults. And then the acute recurrent needs more than 1 attack separated 1 month in between. And chronic pancreatitis is not acute recurrent pancreatitis, and it's heavily an imaging diagnosis at this point. So the background of this is that from single center studies, and this one came from Pittsburgh by Dr. Morinville and Dr. Lowe, while it showed that the catchment population remained stable over these years from 93 to 2004, the incidence of acute pancreatitis did rise over time. We saw a similar trend, and there were multiple other single institution reports that showed this, and we are now averaging about 100 patient admissions of acute pancreatitis per year at one hospital. We know now, though, from 2 at least publications, including one from Dr. Sellers in gastroenterology, that this incidence might have stabilized, and it is about 1 per 10,000. So is it the increased awareness that we're testing more, and that's why we're finding more acute pancreatitis? And that accompanied that article from Pittsburgh, and probably that is part of the problem, or that is part of why we are catching more cases, and maybe because now we're more educated that it had stabilized. In terms of national trends, this is using the Pediatric Health Information System, which is a comprehensive database that captures the major children's hospitals. Acute pancreatitis in the last decade has been on the rise compared to all other pediatric hospital admissions. And the etiologies in children, while in adults it is more split between, for the acute, alcohol and gallstones, in kids it's much more versatile, so they really keep you on your toes. You think about drug-induced more often in children, trauma-related, systemic illnesses, structural and anatomic things, infection, gallstones, while it's cited in this pie graph as 5%, more studies showed a more increasing incidence. And then what's red or idiopathic, it's probably more of the genetic terms that we don't typically test for from the first attack. In children, the vomiting, abdominal pain, and back pain are the majority of the symptoms, but keep in mind if you have an infant or a toddler who are younger in age and they can't verbalize their pain, then their symptoms will be more subtle, like vomiting, fever, irritability, even not tolerating their feeds, distended abdomen, and so on. Gallstone pancreatitis, and this is taken from my colleague, Dr. Tom Lin, who leads our endoscopy center, does happen in children. And I am sad that there are cases where the patients are handled, they're told you have acute pancreatitis. They say, follow up with a pancreas expert. I see them a month later, they still have the same tenderness in the epigastric region, but no one got an ultrasound. So the patient had a gallstone walking in the street, and it's fixable. So it does happen, and sometimes there is a need to do an emergent ERCP if there's suspicion of cholangitis. So while it's one of the most common etiologies of acute pancreatitis in adults, gallstone pancreatitis happens in about 10 to 30% if you want to review the more new literature, including our own from our acute pancreatitis registry. So when we looked at when should we do the optimal management for cholecystectomy even, we had a single center study from our own group that we advocated through the study that early recognition is going to lead to better care because we are going to advocate for early cholecystectomy. And this study showed that the group that underwent that early intervention during the index admission did better and did not come back with biliary pain or readmissions or even acute pancreatitis compared to the group that did it. We developed a model because of the interest for early recognition where you could apply it on admission. And the model used clinical variables that you have from the same patient. And it had obesity, BMI, bilirubin level, and different markers. But to show you kind of just the skinny of it, if you incorporate ALT and the lipase levels, and the higher they are, the higher the likelihood. If you have those two high, then please get an ultrasound and advocate for your patients to get a gallstone evaluation. The area under the curve for this model was 0.85. So pancreatitis complications do happen in children, and when they do happen, you need to seek expertise and care from your pancreatic colleagues, whether they are in a pediatric specialized center or adult center that has expertise and comfort level with children. These are some of the images that show fluid with debris around the pancreas or even an abscess. Children also could develop multi-organ failure on top of those local pancreatic complications. This is a pseudocyst in a child, and then it does happen in about 10 to 20%. And not each pseudocyst requires an intervention like we heard prior, but if the patient is symptomatic and it becomes, especially in the little ones, as big as their whole entire abdomen, then you need to do something about it. We came to a classification of acute pancreatitis and classifying severity just recently under the NASPGHAN, which is our North American Society for Pediatric Gastroenterology. While it might seem similar to how you classify it in adults in terms of if you don't have a multi-organ failure and you don't have local pancreatic complications, then you have mild pancreatitis. If you have local pancreatic complications, then you have moderately severe. If you have organ failure that is transient, less than 48 hours, then you have moderately severe. If you have organ failure more than 48 hours, then you have severe. We needed to go back and define what is multi-organ failure to children, what is SIRS for children, and so on, so that these are pediatric specific criteria. While we have management guidelines available for adults, we did make some strides in pediatrics, and I take pride to be part of this very active community. And these are some of the names that came together in the EPC in Hungary 2 years ago. And we sat in this room for 6 hours and did voting. While we didn't have a lot of evidence and maybe not enough randomized controlled trials, or I would say not at all for the fellows in the room, we are just starting with that aspect and thinking. We really had to start somewhere. So we reviewed all the evidence we have to come up with some management guidelines. And I do foresee that in every 5 years, we have to do this exercise again. Same thing with during the NASP again, and we came up with this nice table so that it could help pediatricians and gastroenterologists everywhere know how to diagnose, what fluid to use, at which rate, and so on. So what are the knowledge gaps now? Is that we had single center studies for acute pancreatitis, which made it very difficult to predict which patients are at risk for acute, recurrent, or chronic. We have major reports that show, this was published in 2011, that while you could have anywhere from 30 to 300 patients at each of these single centers, the recurrence rate is about 7 to 34%. So it's not insignificant. So we designed a prospective study to look at acute pancreatitis from the first attack on. This registry was built in 2013. We currently have a cohort of 170 patients that we've been following and collecting a ton of data on, including biomarkers for research. So we are also looking at some outcomes prospectively, including their exocrine and endocrine and even quality of life measures. So I'm very, very excited for this kind of to see at least even observational studies that we can start. When we came up to this question, we had enrolled 115 patients. That was almost 2 years ago now, and about 17% developed acute pancreatitis in front of our eyes. But what I see helpful from this histogram is that the majority of the ones who would develop recurrence would actually do so within the first 4 months. So who progresses to the second attack? If you looked at all the comers, just looking at their first attack etiology and doing a survival analysis over time, while you see that gallstone and biliary, because you remove the gallbladder, or trauma should not have a high recurrence rate, and these are the lower bars, the higher bars that drive this are really the idiopathic and genetics. And the idiopathic were not tested for the genetics. So recurrent pancreatitis and chronic pancreatitis happen in children. The estimates, as I showed you, are 7 to 34% have acute recurrent. Now we use chronic pancreatitis definitions based on imaging, which is calcifications and ductal dilations. So really it shows the late markers of the disease. So even in pediatrics, we need research for early biomarkers for this disease. So INSPIRE came about, led by Dr. Aliyah Uch in Iowa, and I was her fellow at that time. I tell Dr. Uch I'm still her fellow, because it's a pleasure to work with her, and Dr. Mark Lowe as well. And I learned a ton from helping them establish this beautiful registry that now is international. And INSPIRE came about to really help define how do children go from acute recurrent to chronic, and captures acute recurrent and chronic pancreatitis patients. So we started putting definitions for acute, recurrent, and chronic. And then it's really developing a well-phenotyped cohort of children, and it is the largest to date. And these are the centers at the time that this slide was made, and there are more now. It's 22 centers, Gretchen? Yes. So one of the early JAMA papers from INSPIRE, we had 300 patients, and it showed that genetic factors were heavily enriched in these children. And this was just done as the provider discretion. This is just the 4 most common gene at that time, where they were about 48% in the acute recurrent group and about 73% in the chronic pancreatitis group. And then the second in line was obstructive or anatomic factors, and about 30% in others. Autoimmune could cause recurrent pancreatitis. Toxic metabolic factors were less common, but they happened, like medication, smoking, hypertriglyceridemia, kidney disease, and alcohol. So what did we learn from INSPIRE? We learned a lot, but I'm just gonna summarize some key points. That of the patients in whom new mutations were identified, significant number were screened for 2 genes or fewer. The most common mutations identified in acute recurrent, as Vikash said, is the CFTR, which is because the carrier rate is 1 in 25. The most common of CP was PRSS1. The study also identified patients with cystic fibrosis that they were walking in the street, they did not know they have cystic fibrosis. And we see that also all the time, but they have the atypical CF disease, which just doesn't affect the lungs and affects the abdomen. The combinations of genetics was also evident in about 10 to 15%. And then the children with acute recurrent or chronic had more than 1 etiology or multiple risk factors at some times. We screen for more genes at a time, and this is just a panel that we use now at Cincinnati Children's, and there are other labs that have more comprehensive panels, but we really no longer screen for 1 gene at a time. In terms of management, the clinical trials for low-fat diet, pancreatic enzymes, antioxidant cocktails, steroids, unfortunately, we do not have enough data that it helps children at this point. But what we know is that optimal nutrition and adequate pancreatic enzyme dosing would help. These are growing children, we don't want to miss the boat. Optimizing pain management, as well as endocrine function would be ideal, and plugging them in with the right services at the right time. This is from Minnesota group, and it shows that even if we want to manage with TPIAT, and that's the other end of the spectrum, that they do have a reduction in opioid use as evident as 3 months afterwards. In terms of islet function for younger children after TPIAT, they do have about 50% if they are in the range of 5 to 12 years, and it's about 40% if they have 13 to 19 years of age. You need a multidisciplinary team to achieve this, because whether it's a TPIAT related or centered treatment plan, or even in the beginning when it's acute, recurrent, and chronic. I list here all the other services we have, but I also list some of their roles. So you start with gastroenterology to confirm the diagnosis and help with the issues that I mentioned. Diabetes, risk factors and genetic counseling, surgery to look at surgical interventions when needed, a very close relationship with your radiologist, pain team and psychology, infectious disease, hematology, nutrition, social work, and so on. While there are pancreatitis excellence published on the National Pancreas Foundation, there are also pediatric specific criteria if you want to gather a team or look up a center where you need help. That is over there on their website. Exocrine insufficiency, as I mentioned, is not always chronic pancreatitis. Cystic fibrosis, we say that pediatricians are very comfortable in managing these disorders. Actually, I would argue that pediatricians see these more than adults. They live longer now, and adults are kind of getting more into, okay, how are we gonna just kind of manage the cystic fibrosis? Because they didn't used to live into their adulthoods, and now the median age is more than 40 years. With the advancement in genetic therapy, it's very important that we recognize those. So Schwachman-Diamond, Johansson-Blizzard, and the other syndromes are really congenital things that pediatricians will see, and they will result in exocrine insufficiency. And of course, acute, recurrent, and chronic. And then I do have a cohort that is idiopathic EPI. So I work them up for everything. For the fellows in the room, if you want a project, I just don't know what to do with them, but they only live on pancreatic enzymes. Tumors happen in children, and while they're rare, they could be very, very challenging. So seek expertise and discuss with your surgeon and colleagues early on. Pancreatoblastoma is one of the most common ones that you see. If you have a younger child, typically from neonate age up to 9, think about that in your differential. And this will be the image on the top. I'm sorry, it doesn't project well on this one, but better on that screen. Solid pseudopapillary tumor are second in line. If you have an older age, though, they are the #1 cause of pancreatic tumors. So think about it typically in a female adolescent, and usually they're both amenable to surgical resection, and complete excision would be the cure in the hands of a good surgeon. Pancreatic ductal adenocarcinoma, while it happens in children, it's very rare. Other tumors, endocrine related, neuroendocrine, which could be part of syndromes, or even insulinomas, which could be very challenging to manage. And then gastrinomas, glucanomas, and VIP, and somatostatin. Then non-epithelial tumors like lymphomas could happen, Ewing's sarcoma, or the neuroectodermal tumors. And on the upper image, I show a child we're managing right now. She's still in our vicinity before the chemotherapy, and the one in the bottom is after chemotherapy. Actually didn't need the resection. So the right diagnosis would lead to the right management. I would just throw this out there because it's fun, but I just wanted to inspire the fellows. I was a fellow here in your shoes one day, not just through paper with the National Pancreas Foundation, but putting our hands in together, we really accomplished a lot. We made animated pancreas patients for providers to manage pediatric disease. It's really provider to provider interviews because physicians want a different level of language than the patients. And we also made cartoons for the kids and their families so that they could learn through fun modules. It's all available there on the website. We spent a lot of time and effort and money on this, so I thank everybody who helped with this, and the industry who supported it too, and the National Pancreas Foundation, because it is a tremendous resource. There was nothing out there before these efforts. We do have electives for training, And I would like to see more and more pediatric centers educating and spreading the wealth of knowledge. And stay tuned, we'll probably have like a medical pancreatology training because people are eager to learn about pediatric pancreatology. So it's not a one-man job, but I would say it is a prime time if you like the pancreas and you're a pediatrician. So to conclude, pancreatitis is emerging in children, and a subset progress to a complicated course or recurrent and chronic, and both are troubled. And then conditions affecting the pancreas are unique. They require really a pediatric-oriented, let's call it, pancreatology expertise. You don't have to be a pediatrician, just work closely with the people who really have that expertise. To ensure the best patient outcomes, we need education for the providers and the patients, and really a multidisciplinary team is what's gonna make it happen. So by that, I conclude, and thank you all.